Hi, everyone, and thank you for joining us for another episode of the Voice of Pancreatic Cancer podcast. I'm your host, Miranda Weinberg with the Sina Magowitz Foundation. And if you don't know about us, we are a nonprofit that's dedicated to the awareness, prevention, and cure of pancreatic cancer. I'm honored today to be joined by Dr. Mandana Kamgar from the Medical College of Wisconsin. And we're going to be discussing Neoadjuvant Therapy 101. So welcome, Dr. Kamgar.
Thank you very much. Thanks for having me.
We're just really excited that you took some time out of your busy schedule to discuss this important topic with us. Before we jump right in, I did want to just start out with some happy news that came out a couple days ago about the 5-year survival rate jumping to 13%. And we're really excited because this is the third year in a row that it jumped in a percentage rate. So I was curious what your reaction was to that.
No, I think that's great news, and just hopefully this will be the beginning of the years to come that the outcome for pancreatic cancer will improve. And I think it really reflects the effort of all the investigators to bring on good studies and all the brave patients and families that they go into these studies so that they can advance the science in pancreatic cancer and improve the outcomes.
Yeah, I think a lot of families are really excited to hear this, just reemphasizes the message that we're trying to spread, that there is hope. So we're excited about it. And before we get into neoadjuvant therapy, I was curious if you could just give us a little bit of background on you and what brought you to the Medical College of Wisconsin and what sparked your interest on pancreatic cancer specifically.
Sure. So I did my medical studies back in Iran. I came here and then I did my internal medicine residency at Cook County. I did my fellowship for hematology oncology at Karmanos Cancer Center in Detroit. And from the beginning of my oncology training, I was very interested in pancreatic cancer in general. Another interest that I have always had is translational research, meaning trying to bring what is done in lab to the clinic so that those new findings can be applied in our patients to improve the outcomes. And I think understanding the challenges in pancreatic cancer, I think this is a great area to really try to do translational research because there is a lot to be done. And I think I wanted to be part of the whole team that is trying globally to improve the outcomes in pancreatic cancer.
That's awesome. So we're gonna, jump straight into neoadjuvant therapy. In a nutshell, how would you describe neoadjuvant therapy and its role in cancer treatment, specifically with pancreatic cancer?
So the term neoadjuvant therapy, basically it means that we are giving treatments prior to going to the eventual surgery. So in reality, in pancreatic cancer, the true cure comes with the successful surgery, which means trying to take the cancer out and not leaving anything behind. So everything which is used pre-surgery is used with the hope of increasing that option, increasing the chance that our patients would be able to get cured with the surgery. And in general, it normally includes some months of chemotherapy, which are systemic drugs given to try to prevent the cancer cells from growing and, if possible, kill the cancer cells. And at our center, we are strong believers in radiation treatment as well. So that's a specific treatment that is focused locally to the area that the cancer is in the pancreas, with high beam of energy delivered. The whole idea is to try to kill as much cancer cells as possible and sterilize that area before surgery. So basically, the neoadjuvant therapy consists of a combination of chemotherapy, radiation therapy, and then eventually going to surgery.
Okay, and then what's the contrast between that and adjuvant?
So in general, there are some changes, meaning that in the adjuvant setting, you're basically trying to give your treatments post-surgery. Could be the same, could be chemoradiation. There are challenges, however. One challenge is that post a major surgery, not everybody will be able to really get adequate chemotherapy. Even sometimes up to half of patients really don't recover adequately at times to get a good systemic chemotherapy. And also in that setting, we are post-surgery with organs that are also starting to improve. So sometimes radiation or heal from the surgery. Radiation can sometimes be difficult because now we are radiating that area. And I think the third challenge in adjuvant setting, meaning post-surgery, is in truth, we don't really know whether there is any cancer left behind, and we don't really know if the cancer is responding to our treatments, which is as opposed to the pre-surgery that we have a mass, we have a cancer, we can follow, and we can see how the treatments are working and whether we are on the right track for this cancer.
Okay. And in relation to both of those, what are the difficulties with pancreatic cancer specifically when putting neoadjuvant into practice?
So I think the challenge is that although sometimes, or in a subset of times, we do the scans, we think that we have really caught the cancer in a very early stage, meaning a stage that it is localized to the pancreas or sometimes even to regional lymph nodes. In reality, we can miss very small areas of a spread of the cancer that we call micrometastases. And unfortunately, pancreatic cancer has a tendency to have those micrometastases early on. And that's the whole idea, that these areas, these spots could be in the lung, could be in the liver, could be in the peritoneum. And the whole idea of the systemic therapy, such as chemotherapy, is try to give a treatment that goes through the bloodstream, goes to all of these areas with the hope that it finds these small areas of a spread and eradicate them before eventual surgery takes place.
And I'm sure that, like you said, early diagnosis plays a major role in the effectiveness of this.
Yeah, and I think the challenge with pancreatic cancer, I'm glad you brought this up, has been basically trying to find the right screening. So we have other cancers such as breast cancer, colon cancer, that they have been active and screenings that have been going on for so many years. They have already improved the outcomes and early diagnosis. In pancreatic cancer, unfortunately, a lot of times it's diagnosed at a stage that it starts to cause symptoms, which at that stage already it is somewhat advanced. There are not great screening studies yet. There is a lot going on in terms of early detection and also high-risk clinics for people that we know might be of higher risk for pancreatic cancer. But I would say, unfortunately, one of the challenges still remains in finding the cancer early on, even possibly before we can find it on CT scan and imaging.
And if for someone that is diagnosed in different stages, let's talk about the stages and how the therapies can be different.
Sure. So I think, as we discussed, a very important part of treatment of pancreatic cancer is the surgery. So while it has stages such as other cancer, the stages of 1, 2, 3, 4, 4 meaning metastatic, or when the disease has already spread through the bloodstream to other organs and is growing, other than 1, 2, 3, there is a more practical staging system. And that means how easy or how potentially successful would a surgery be. And then it starts with the easiest or most potential success, which is resectable, meaning that the cancer is really, by the imaging, really limited to the pancreas itself without involvement of other organs or other lymph nodes around. And that's
resectable.
That's resectable, correct. Okay. And then as the cancer grows, the challenge is that pancreas is in a very strategic area. A lot of major and vital organs are there, and a lot of large blood vessels that include blood supply to the whole intestines, that without that blood supply, our body cannot really go on. So depending on how much the tumor is going towards these blood vessels or encasing these blood vessels, it really determines, in truth, can this cancer be taken out? Because we know that some of these blood vessels cannot be cut. So if we don't cut it, the cancer will still be behind and it will grow after the surgery. So these stages then become from resectable, it goes to a bit like borderline resectable. Still, the blood vessels are not a major problem. Maybe we have a lymph node, maybe it has touched a blood vessel, but it's still surgically possible to take it out. And then we go to locally advanced, which is a stage that it has really started now to encroach and to really surround the blood vessels with major blood vessels, and without a major vascular reconstruction, meaning cutting and reconnecting, we will not be able to do the surgery, to even sometimes so locally advanced, so much advanced that there's no way that this can be surgically taken out. And mostly the treatments become very much like more advanced or metastatic disease, which is just systemic treatment and potentially local treatment to try to control the disease, but not surgery.
Okay. And then is neoadjuvant suitable for every stage that you described?
So theoretically, a study will be considered, like a treatment will be considered neoadjuvant if eventually we reach the point of surgery. The staging system is very important because as we are asking our patient to go through months of treatment, the goals of treatment should really be clear. How likely is it that we will eventually reach the point of surgery? And that's why it is important, because while resectable situations, more than 90% will reach that, or while in locally advanced, more than 75% will reach that. As the stage goes up, we might come to 50%, 25%. So the chances that in general we would be able to reach the surgery would decrease somewhat as the stage becomes more and more advanced. So I think in general, neoadjuvant therapies is considered at a time that we think there is still a chance for surgery. If we don't think, that means that if our radiologist or surgeon has reviewed the images and they really believe that there is no way that this cancer can be successfully be taken out without leaving anything behind, then that's the treatment for more advanced disease. That's not considered neoadjuvant or pre-surgery.
Right. Okay. So, as far as like, we talked about at the beginning of the episode, advances and clinical studies and trials and different things. Are you seeing anything that's like exciting to you happening recently in this arena?
Absolutely. I think you mentioned about improvement in outcomes, and I think that reflects that the changes and the improvement in the systemic treatments that we have had. We started from just one drug that had some effect, but a lot of patients would not have benefit from it, to now combination chemotherapy that has much improved outcomes. We are now having molecular tests that we can look at the tumor and classify them and try to really see if we can find a right treatment for the right patient rather than just randomly using a treatment. And also, though still in the development, we are now looking at potential vaccine studies, in the pre-surgery, in the post-surgery, or even in the early detection phase, trying to see if the immune system can be activated against the cancer so that our own immune system starts fighting against the cancer. So I think these are all exciting advances that I believe that in the future will serve at least a subset of our patients. So I think it's yet to be determined how successful they will be and how many of our patients will benefit from it. But I have faith that it will be an active treatment eventually in the years to come.
So you mentioned, the molecular profiling. The genetic profiling plays a part in that as well?
So in general, there are two main tests that we do as every patient with pancreatic cancer is diagnosed. Irrespective of a stage, we do it for all of us stage at our center now for our patients. One is that as the biopsy of the cancer takes place, the cancer tissue is taken out, we are trying to really look at cancer and see what happened in a molecular level, mostly looking at the DNA which is the center that really has all the codes for each cell that dictates the function of each cell. We are looking at DNA and we are trying to find what misspelling or mutation happened in it that made the normal pancreas turn into cancer. So that's called genomic profiling, or basically taking the cancer tissue out, sending it to molecularly be tested and trying to find the drivers of the cancer. On the other hand, there is another test. In this test, which is called genetic test, we really don't look at the cancer cell, we look at the normal cells, meaning that we are trying to figure out if our patient has inherited a misspelling or a mutation in the DNA that would predispose them to develop cancer, meaning that is this cancer as part of a hereditary condition? Is this a gene that they inherited and that increased the risk of developing cancer? That is the genetic test. So for all of our patients, we do the genetic test, we do the genomic test on the tumor, and then eventually we will use these two to try to figure out, first of all, what is the best treatment for our patient, and second, is there any family member at risk, understanding the genetic testing that would also need to be tested so that they can potentially undergo screening for cancers earlier on.
And the genetic testing, is that where like the biomarkers is coming into play?
So when we do the testing as specified, I think with these testing, basically we are trying to know the backbone of normal DNA and now the cancer DNA. And with that, not that every finding, unfortunately, we can't really translate every finding to a treatment, but there are subset of times that when we find something, we know that, for example, a certain chemotherapy might do better. So we use that treatment. Or let's say we know that this type of cancer is very susceptible to radiation. So we might do that. Or we might say this type of cancer has a very high risk of spreading early on. So we might be a bit more aggressive with our systemic treatments. So basically, it's giving us some hints about the behavior and biology of the tumor. And we are trying to use those to try to adapt our treatments based on that so that we can increase the success in each individual with the cancer and understanding the unique features of their tumor.
And this is a pretty new concept, right? I mean, when did this start coming into play regarding treatment for pancreatic cancer?
I would say it has become possible because the tests that were previously very time-consuming and expensive became rather widely available, and that's companies that do these tests. The insurance coverage covered them. So they became available to be done in a matter of short weeks, and the result become available to us. And that has been within the past, I would say, decade or such, and now definitely in the past few years, much more common to be used. And as we are getting more and more information, and as we are getting better and better in doing these studies, I think we are utilizing or figuring out more and more biomarkers. So this is rather new to be really used in an everyday life, but at the same time, this is early on in its development. So it's expected that in the future years, our understanding of the tumor and how we can apply these tests will really improve. So the hope is that eventually we will be able to provide personalized or individualized therapy for each of our patients so that we increases the success of treatment irrespective of stage for all of our patients.
And this is really exciting. And is it in a clinical trial currently at Medical College of Wisconsin?
So all of these start as a clinical trial, and that's why we always encourage our patients to participate in trials, because that's truly the only way that we can really advance the science in pancreatic cancer. But some of them, they have already reached the point of clinical use. For example, we know that some of our patients which have specific type of mutation called BRCA mutation, they might really benefit from certain chemotherapies that have a certain chemo, like they are called platinum agents, meaning that one of the drugs in that combination drugs is of a certain family that we know can really affect these cancer cells much more than the other chemotherapies. So we already are using it. If you find BRCA, we say, hey, this type of chemotherapy might be better for you. Or there are subset of pancreatic tumors that are really not driven by the KRAS, which is the most likely oncogenic mutation in pancreatic. The subset that they don't have it, they have technically like switches that are turned on, and we have drugs that turn that switch off. We call targeted therapy. So there is becoming like there are subset of patients that we can potentially already use FDA-approved targeted therapies in that situation. It's a bit more advanced in the metastatic setting, but we have studies at our center that is now bringing them earlier on to the neoadjuvant or pre-surgery setting. So I would say for sure this area of targeted therapy, immunotherapy, these are areas that are now coming earlier, coming pre-surgery, and we are trying to improve the outcomes, hopefully increase the cure with those measures that we are taking.
Okay. So on going back to neoadjuvant therapy, and we talked about, all of the benefits, are there any, I guess, negatives that would discourage a patient from choosing that option?
So I would say while we want to really use neoadjuvant therapy, and again, because of multiple reasons, because our patients are healthier and pre-surgery, so they can tolerate treatment better, because if we can eradicate the early metastasis, the risk of recurrence is less, so we are increasing the chance of cure. And also because, again, we have a tumor that we can really monitor and make sure we're on the right track. These are the benefits of neoadjuvant, but there are for sure downsides. And I think the more a center is a pancreatic center and the more experienced they are, the more they know how to deal with this to make sure the outcome of our patients don't change. One challenge is that the average age of our patient is 69 to 70. So this is a disease that happens in more advanced age. So as we are talking about months of systemic chemotherapy, it can really affect them in terms of causing them to become more tired, fatigue, side effects. So it's very important in the neoadjuvant setting when we are giving these drugs to monitor our patients closely and make sure that we are not making them too weak that eventually they cannot get the surgery that we hope can cure. Second is that we have to monitor this cancer very closely. We have to make sure that we are giving the right treatment to our patients. So we have really set times that we do the scans, and we have a multidisciplinary, all of the different subspecialists sitting and reviewing them at each time set to make sure that we are on the right track and we are improving the outcomes and the cancer is responding and we are not using a treatment that is basically not working. The third thing is that while we might set a plan in the beginning, things might change, toxicities might happen or something changes and then we have to adapt our plan. And I think that's why it's important to have a center with a lot of experience and with good team of having subspecialists to work together to make sure that as our patient's condition changes, we also adapt our plan and really try to now come up with the best plan with the changes that have happened.
And that's why, like you said, being in a practice that is very specialized in pancreatic cancer is important.
Absolutely, yes.
Okay. All right. So as we kind of just wrap up, what advice would you give to a pancreatic cancer patient or caregiver that is, considering this path for their treatment for their loved one?
So in general, this diagnosis by itself is a challenging diagnosis because the outcomes have not been the best. There's a lot of negative image out there for it. So there's a lot of stress over our patients, our caregivers. So it's understandable that during those times, it's really hard to figure out the best option and the best choices. But I would say one very, very important aspect is to really try to be in touch with a center which has, they're really experts in pancreatic cancer care. Because while some things can easily be given locally, you really need a good leader. And that leader, majority of the time, is a very experienced surgeon that really determines what steps should be taken so that the success of surgery is higher. So I really encourage our patients that have good academic centers or good pancreatic centers next to them to really go there for an opinion about the surgery. As many times doing a surgery in these high surgery centers, that the centers that they do many pancreatic surgeries, it's shown to improve the outcomes of our patients. So it's very important that if they have a center close that has expertise, try to get their opinion, see how many of the treatments can be safely given locally and take advantage of that. But if there are certain aspects of treatment that would really better be happening in that specific specialist center, I think trying to really go and participate in that aspect in that center, these can all improve the outcomes and improve the chance of cure for our patients.
Yes, and if someone feels like they're not in a place like that, not to be afraid to seek an additional opinion, to reach out and switch their primary, caregiver. I know there's a lot of fear.
And also, sometimes the treatment does not have to be delayed, meaning that they can, like, if the plan is to give chemotherapy, sure, that plan can be already started. But I think as the treatment is going on, I think trying to really establish care with a center, be evaluated by an expert surgeon, I think that will help just to make sure the whole plan goes smoothly and goes in the best potential direction for each scenario that might happen.
Okay. Well, thank you so much for your time. I think this has just been very beneficial in understanding all of the benefits and even some of the negative aspects of neoadjuvant therapy. Is there anything that I missed? Anything else that you wanted to add?
No, I think the only thing is that, and I don't know if this is the place to discuss. We have on YouTube there are small videos for education of patients. I don't know if you're aware that it's called Pancreas School.
Yes.
Yeah, so I think some of them are really helpful because they really focus on what is this, what is that, what is the staging, what is the Whipple. So I think that those are rather helpful. We are increasing the number of videos. Like we will have something for advances in like targeted therapy, KRAS treatment, like, advances in chemotherapy. So I think those can potentially also help, your listeners or people who are viewing this to learn a bit more about these sub aspects of treatment, basically.
Yes, and I'll be sure to include the link to those in the description so that anyone that's, any of our listeners, if they're interested, they can click and find out more about the Pancreas School, which I agree it's an amazing benefit.
That's
amazing
great
resource. Yeah.
And thank you very much. I think in general, I've had a lot of patients that have been in touch with Cynomegaloids, and they really, really appreciate all the education, all the support that they provide. So it really has done amazing work, and it really means a lot to a lot of our patients.
Thank you for that. We're passionate about patients and we're passionate about research. So all of this was extremely helpful, and appreciate your time, and hopefully we can have you again.
Absolutely. That would be my pleasure. Thanks for your time.
Thank you so much for joining us for this episode. If you were encouraged by it, or you know someone who you think might be encouraged by it, we would like to ask you to share it with them, and also like our channel and subscribe for more educational content, more stories of hope. I do also want to plug that we have a support group called Pancreatic Cancer SOS. It's led by patients for patients. We meet twice a month through Zoom, and we would love to have you join us. Thanks so much for listening.